So, good evening, doctor. My name is Dakshata, and I'm from Glenmark Pharmaceuticals. And it gives me immense pleasure to welcome you all for today's scientific session titled From Evidence to Practice, a Role of Fluticasone Furoate and Vilantrol in Asthma Management. We all would agree that asthma remains a heterogeneous disease, and over past few years, Vilantrol and fluticasone combination has emerged as an important option owing to once a daily dosing, its sustained bronchodilation, and a strong anti-inflammatory efficacy over other conventional ICS LABAs. Today's discussion will highlight burden of uncontrolled patients on conventional twice a daily ICS LABAs and current Indian evidence of fluticasone furoate and vilantrol in different asthmatic patient profiles. With this, now I would like to introduce and welcome our speaker and moderator for today's session, Dr. Rajesh. Sir, it gives me immense pleasure to welcome you for the session. Talking about doctor, I'll just share my screen just a minute. So talking about Sir, then he is a senior pulmonologist with extensive clinical experience in asthma and chronic respiratory disease management. He is actively involved in evidence-based practices and translating clinical research into real-world care. He is known for his expertise in optimizing inhaled therapies for improved asthma control and patient outcomes. And currently, doctor is based at Rajagiri Hospital, Kochi. So, sir, welcome for the session.
Thanks a lot.
With this, now I would love to introduce our eminent panelist. So, first we have Dr. Mujib Rahman. So, doctor is pulmonologist. He's expert in sleep medicine and currently is based at VPS Lakeshore Hospital, Kochi. So, welcome, doctor. Then we have Dr. Atul Francis. So, doctor is also an expert in respiratory medicine. He's a consultant pulmonologist and currently he is based at Augustine Jubilee Hospital, Kochi. So, welcome, doctor.
Yep.
Then we have Dr. Joel Andrew. Doctor is also an expert in respiratory medicine. He's a consultant pulmonologist and currently he's based at NIMS Hospital, Manjeri. Then we have Dr. Surya Kala. Madam is also an respiratory medicine expert, consultant, and interventional pulmonologist, and currently she is based at BMH Hospital, Kannur. So, Madam, welcome to you as well. And with this, I will hand over the session to Dr. Rajesh. But before that, for everybody, this program is brought to you by the makers of Velour F, 100, 200 MDI and 50 and 100 DPI, and Velour FG, 150 MDI and 100 DPI. So, doctor, with this, now I would love to hand over the session to you.
Thank you, Dr. Dakshita, and a great moment of gratitude to you as well as Glenmark team for initiating this very, very informative webinar, something that is very relevant because asthma is one of those bread and butter diseases of the practicing pulmonologist. And although we know that a substantial chunk and proportion of asthma is easily controlled with any ICS LABA, there is a small subgroup which is not amenable, which defies control even with our conventional ICS LABAs, which might require higher therapies, including triple therapies and biologics and all those things. And the Indian clinician actually is spoiled with choices because there's a lot of ICS LABA combinations that are available in Indian market. So how do we compare and contrast each of these? How do we select one particular agent upfront or even think of changing one agent to another? This is something that is always a enigma to the practicing clinician, and this is what we are trying to share or dissect out in the next few minutes. So we'll have a very short 15 minutes presentation, and I will try to dedicate maximum time to the panel discussion with the eminent pulmonologists that you have assembled here. So I'll just share my slides. So, I mean, this definition of asthma, all of us do know that it's a chronic inflammatory disease, episodic symptoms, etc., huge burden, huge number of asthmatics in our country. So, in fact, almost 13% of the global asthma burden lies in India. with almost 42% of the global asthma deaths happening in India. So probably India is an asthma capital of the world. And what is important is what Mrs. Dakshita told, that asthma is a heterogeneous disease. So although we have dumped many of those patients with similar clinical characters and similar phenotypic mechanisms into one diagnosis of asthma, each patient is unique. So that is something that we need to understand. And if you look at the Global Initiative of Asthma Guidelines 2025, they look at two broad aspects of asthma, that is the goal of treatment. The first one should be that the patient with asthma is very well controlled with regard to his symptoms. So hardly any symptoms, quickly relieved symptoms, normal sleep, not awakened by any of those asthma symptoms, normal and unimpaired physical activity. So no symptom at all. So that will be the best way that we can treat our asthma patients. That is one aspect. The second aspect would be minimize the risk of future asthma problems. That is asthma exacerbation, no exacerbations, normal or stable personal best lung function, no requirement for toxic drugs, including oral corticosteroids, and no, whatever be the intensity of treatment, no medication-related side effects. So that is an idealistic goal of asthma management. And we know that the treatment for asthma goes upward depending upon the severity or the intensity of treatment that is required for asthma control. We usually prefer a step-up approach, although many of the clinicians nowadays prefer a intense hit and step-down approach also. Now, SMART, or the single inhaler maintenance liver therapy, is something that is emphasized in the early steps of asthma care in GINA. So traditionally, most of those SMART studies were AstraZeneca-sponsored studies being done with formoterol budesonide. But even if when we look at those studies which established the place of SMART in asthma care, it is to be mentioned that those patients who are on SMART, around 40% of them were uncontrolled or only partly controlled. So it's not that one strategy of SMART will fit in all asthma patients. One size does not fit all. So why should we look beyond? As I said previously, many of these patients are not optimally controlled. So in addition, we have frequent exacerbations, nighttime symptoms, ER visits, etc. continue to occur even when we treat the patient with SMART. And we have other than budesonide, we have other potent inhaled corticosteroids with very high receptor affinity and very wide therapeutic index. So why don't we look at other options other than the SMART with the FB alone? And we have patients, asthmatics nowadays, with multi-morbidity like cardiac disease, obesity, diabetes, etc. And they might benefit with more targeted long-acting beta-2 agonists. And we have also once daily regimen. So if the patients are not compliant to a BD dose, then why don't we look at OD options? So if we look at fluticasone as a inhaled corticosteroid, it's perhaps the ICS with the highest GR binding affinity and very low systemic bioavailability. And it has a much better longer protection with FF as compared to budesonide, fluticasone fumarate as compared to budesonide. And if you look at vilandrol as a ultra LABA, it has a very high beta 2 receptor selectivity and it has a very fast onset of action. So theoretically, even the vilandrol containing ICS LABA formulations can be used as SMART. And the best part is that they are extremely cardioselective. So even patients having a lot of cardiac comorbidity, this is one agent which we can use very safely. So we look at a few clinical evidences of initiating VF, that is vilandrol fluticasone, as an upfront agent in newly diagnosed asthmatics, as well as changing those patients on other ICS LABAs who are uncontrolled to a combination of VF. So this was one study which was published in 2025, and it was seen that if the patient, it compared patients who were initiated upfront on VF versus FB, that is vilandrol fluticasone versus formoterol budesonide. And it was seen that the time to first exacerbation was much better if the patient uses VF, that is vilandrol fluticasone, as compared to formoterol budesonide, to the tune of around 40%, the risk of exacerbation and the time to first exacerbation. And the exacerbation rate also was substantially lower with VF as compared to FB. And most importantly, since VF is an OD dosage formulation, the compliance is expected and the expected to be better, and the total ICS burden is also expected to be burden. So, I mean, it's expected to be better. So, the compliance as expected was much better with VF as compared to formoterol. So that much about upfront initiation of VF in newly diagnosed asthmatics. Now, in Indian scenario, the more meaningful aspect will be someone who is already on an ICS LABA, medium dose of ICS LABA, and still is not controlled. As we said previously, almost 40% of those patients who are on SMART are still not controlled. So this is a real world study. I don't think it's published, so it's still in the file with Glenmark. It's subjected to a peer review. That's what I was made to understand. This was a 12-week study. So patients who were on other ICS LABA combinations and who were not controlled, twice daily conventional ICS LABA combinations, they were enrolled into this study where VF was used as a changed ICS LABA combination. So 12-week follow-up study. Around 177 patients were enrolled in this study, and of this, almost 64% of them were initially on a SMART strategy with formoterol budesonide. They were significantly symptomatic patients with the ACQ score of 2.5 plus or minus 0.5. And it was seen that by the end of study, that is the 12th week of study, there was an improvement in trough FEV1 to the tune of almost 250 ml. So that is substantial. Even the trough FVC increased by around 346 at the end of 12 weeks of therapy. Significant improvement in the ACQ, asthma control scores. And what is more important was that most of these patients, almost all of these patients had, I mean, not all, almost half of these patients had at least one exacerbation in the past year. So in the 12 weeks, they were followed up. Yes, 12 weeks was a short period, but only a very small proportion of these patients had any exacerbations. So that way, although we need a longer duration study to prove that, but there is some pointer that this VF combination has the potential to reduce subsequent exacerbations when a regimen is changed from an alternate ICS LABA to VF. Even the need for rescue medications were decreased by the VF combination, that way proving that the asthma control is better. And in a subgroup analysis, that is patients with persistent asthma. So in patients with persistent asthma with fixed airflow obstruction, even this subgroup of patients fared very well with the use of VF. And there are patients, a subgroup of patients with uncontrolled asthma who are frequent requirers of oral corticosteroids. So even in this subgroup of patients, it was shown that the PROMIS study, the improvement in with frequent OCS users was also pretty good. So based on this, an Indian consensus has been formulated, and there what they suggest is that as the positioning of ultra-LABA ICS as exemplified by the VF combination, in step 3, a medium dose of ultra-LABA ICS may be a worthwhile strategy. In step 4, a medium dose of ultra-LABA ICS plus or minus a LAMA may be a strategy. And in step 5, even a high dose ultra-LABA ICS plus LAMA may be a reasonable strategy. So the summary of whatever I said up to now is that in a substantial proportion of asthmatics, even despite the conventional therapy, that is a SMART strategy with FB, there is a substantial chunk of patients who have high burden of symptoms and uncontrolled asthma to the tune of around 40%, and that is pretty big. In this subgroup of patients, the treatment choices should be tailor-made rather than following the dictum that one size will fit all, that approach. And among the ICS LABAs, VF, that is Vilandrol, fluticasone furoate, is an excellent option because Vilandrol is a very potent and a very highly selective beta-2 agonist with rapid onset and long duration of action. The advantage is the rapid onset, so it can be used as a SMART if you feel so. It has long duration, so it can be used as an OD treatment. It is highly beta-2 selective, so you can comfortably use it in patients with various cardiovascular comorbidities. And because it is potent, it gives an excellent bronchodilation. And if you see the second component, that is fluticasone furoate, it has a very high glucocorticoid receptor affinity, very low oral bioavailability, high potency and a wide therapeutic index. So the risk of pneumonia with FF, that is fluticasone furoate, is much less than budesonide or even fluticasone propionate. And Indian evidence has shown efficacy of the VF combination in asthma patients with persistent asthma and high symptom burden. And with improvement in asthma symptoms, there is a significant reduction in subsequent exacerbations, and liver use was also decreased. And high patient satisfaction and adherence. So maybe VF combination is something which we can think of using as an upfront option in newly diagnosed asthmatics, as well as patients on other ICS labas who are suboptimally controlled. So with this, I come to the end of my presentation, and I'd be happy to share any comments from the Elite panel. If anything is there, you can share it now, and otherwise we'll go to the panel discussion per se. Dr. Dakshita, anything to mention, or shall we go to the panel discussion per se?
I think we are good to go for the panel discussion. But before that, I have one question since we are just done with the presentation. I would just want to know from each of the doctor. I mean, since we are talking about Vilantrol and fluticasone, I would want to know that what would be that ideal patient profile from your a practice where you particularly use this combination. So I just wanted to know the ideal patient profile or any patient profile where you're using this combination.
I think Mujib, we can start.
Okay, good evening, sir. I think my view and as well as the literature evidence, I will be very happy to start somebody who is very busy, who is not adherent to BD dose of asthma medication, and who prefer to have at least once daily medication. That is the first group of patient I would be going ahead with the Vilantrol fluticasone. Second group of patient is that asthma is they are using other combination like formoterol or salmeterol and their asthma symptoms are not pretty much controlled. In that group of patient, trying a very good molecule with a good potency, good affinity to beta 2 agonist, a good potent steroid will be better. These are the two candidates of patients I preferably would like to switch to Vilantrol fluticasone or start upfront the Vilantrol fluticasone.
I think anyone wants, Adul, you want to add something, Surya?
Basically, first is based on patient preference. As I was saying, if it's a working class population, for people who keep forgetting to use their inhalers twice a day, so once a day regimen is there. And especially if it's a step 3 or step 4 gina asthma and it's not responding to your smart therapy, that is your formoterol budesonide combination of whatever combination we are using, and we are not getting significant results. And even if there is nocturnal symptoms or early morning symptoms, even after using the smart therapy, in such patients, I try switching over to the Vilantrol fluticasone combination. So mostly it's depending on the patient preference as well, and if it's a working class population. And obviously, if there is no improvement for the patient or no improvement in his symptoms with the inhalers that he's already been using, and then I try especially step 3 and step 4 instead of increasing the corticosteroid dose of the budesonide. So I just try switching over to fluticasone and see.
Surya and Joel, you want to add something?
Yeah, before like shifting over, I would just check whether the patient is like adherent to the current inhaler usage, whether their technique is good or not. And also will rule out other like any comorbidities which is left untreated, whether if the patient is having some nasal symptoms, whether that rhinosinusitis is being treated or GRD and other symptoms. If that is everything is controlled, still the patient is not improving. And as Dr. Atul said, like if the patient is having more of a like night symptoms, like more of night awakenings because of severe like chest tightness or wheeze or predominant cough symptom and also early morning symptoms. Usually in those cases, I think they will definitely benefit from once daily, which has a like longer action 24 hours, and patient will have a reduced symptoms, especially in the morning times, because most of the time when we come like the patient complains is there is decreased like sleep or there is disturbed sleep. That is the main complaint. So for a better tolerance and adherence, I think I would recommend once daily in those patients.
Thank you. So you need to get the basics right before we think of changing the inhalers. Correct.
Yes, yes.
Dr. Joel?
Good evening, sir. Good evening, everyone. I agree with every other panelist. Few things I need to add. One thing will be treatment naive patients. The patients who have not taken the treatment for asthma coming to us when we need to initiate a treatment for their patient preference. The once daily dosing will be a better choice to offer them. There I will be preferring this combination. The second thing will be a small airway disease. When there is an asthma COPD overlap, there also this combination will be a preferable one compared to the smart therapy.
Okay. So I think very good insights from all the four of you. So we'll just move to the panel and have more opinions from all of you. So I think let it be a very, very informal discussion. So anyone who wants to add on can add, but I think I will just start again with Dr. Mujib. So, I mean, I think this is a very clinical question, I feel. So what are the earliest warning signs that asthma control is deteriorating even before lung function declines? Nighttime awakenings, early morning symptoms, reduced exercise tolerance, are these predictors of impending exacerbation? I think very straightforward question, but Mujib.
Yes. Yeah, because lung function deterioration will be the last thing we see in asthma patients, because before that, pretty early patients' daytime symptoms, the cough, and also the night symptoms, and also the excess use of SABA as a reliever, and limitation of activity. These four aspects should be looked, and also the exacerbation number. The five aspect of the patient will be checked very clearly, so that if there is more daytime symptom, more nighttime symptoms, and limitation of activity and more number of exacerbation, then I think even before looking at the PFT, we should treat this patient, and we should think that his asthma is not controlled at all, or poorly controlled.
I think all of us 100% agree with that, in the sense, I mean, we don't keep monitoring lung functions in asthma patients, and asthma is an intermittent disease also. So sometimes nocturnal symptoms and maybe poor exercise tolerance will be an early predictor. I think there is no controversy there, simple question. And second, moving to Atul. So anyone can chip in after Atul's comments. So I think this is something which we already discussed, but what advantages have you observed with VF apart from adherence compliance in your asthma patients over smart therapy? So do you perceive that VF is superior to FB smart?
Okay, sir. So basically, as I told, I usually, if the patient is not improving on an FP Smart, that is when I switch over to Vilantrol fluticasone. So one thing, what even literature says is, because Vilantrol, it's an ultra long-acting LABA, it has a sustained bronchodilation which is there. So even the trough levels are a bit better compared to the other LABAs which we have, because formoterol, when you take it, although the onset of action is pretty fast, but that sustained bronchodilation is something which we don't achieve, I feel. And with fluticasone, it's a more potent, according to literature, more potent steroid when compared to budesonide. So in that way, I have seen significant improvement in symptoms of the asthma patients, decrease in the reliever use, and especially because it has a sustained bronchodilation and that trough FEV1 is maintained, and because of the long duration of bronchodilation, there is significant improvement in the nocturnal symptoms as well as the early morning symptoms. So that is where I feel, because that Vilantrol molecule also makes a huge amount of difference, even when we are using it in COPD patients as well. So that is where, so compliance is obviously there because it's once a day, and that is one advantage which is already there. And because of the pharmacological properties of the molecules, I have seen that also gives some advantage to the patient. And obviously, we are switching over. In my practice, I switch over those patients who are not improved on the smart therapy. I don't use it as an upfront molecule. So that is what's.
Okay, I think very well put forward, Adul. I think any comments from Dr. Surya, Dr. Joel, Mujib? I mean, one
The
thing that
beta 2 selectivity and cardiac safety
exactly
can be an additional benefit.
Yeah, even I wanted to put that across, because I think elderly patients, elderly asthmatics with some degree of cardiac problems, I think Vilantrol becomes perhaps the safest LABA. So I think that is one at least theoretical, but I think that's practical also. We get a lot of safety profile with Vilandrol. So I think
One
third
thing,
question, yeah.
so one thing I would like to, because the high symptom burden, because most of our asthma patients with a high symptom burden, but I have noticed that patient may not be that much happy with the once daily medication in Indian scenario. So many of the time, patients are switched to once daily. They may have a tendency to use other SABA, or we may have to prescribe something SABA or nebulized SABA or another levosalbutamol or salbutamol along with the Vilandol fatigue sometimes, because patient satisfaction sometimes will be affected. At least in 20 to 30% of the patients who are very symptomatic may not be much happy with the once daily medication because of symptom burden.
I
That
think
is so.
that's
That
an
is as
excellent practical
yeah.
point. Yeah.
Yeah, as Mujib mentioned, it's a very important point. So I have noticed that in my practice also, like patients who have been already used to like twice daily therapy, when we like suggest them once daily, psychologically they feel like they get better relief with twice daily therapy only, and it takes time for them to get adapted to this once daily. Though they have a symptom control, still they would come and ask me, like feel like morning time, what should I do, or whether I should go for a nebulization or should I go for another inhaler. This question is still there in the practice.
Okay, I think a very, very important practical point. So I mean, a substantial chunk of them may be a emotional dependence on a BD inhaler. Maybe you never know in some patients whether the effect is tailing off by around say 20, 22 hours. That also we don't know, but it is something which we practically face. So I think I mean that's the flipper side of it also.
So it gives an advantage in starting inhalers in a region where there is a stigma regarding starting inhaler. In my region, there is a stigma regarding starting inhaler. So once a daily dosing, when I am advising someone to start an inhaler, that too on an OD dosing, patient may become little more satisfied in starting the treatment.
Okay, so acceptance is better with the audio
Acceptance is
dosing.
better.
Yeah. Okay.
In a
Okay.
naive patient, acceptance is better.
Okay. Okay. I mean, these are all practical points which never come from the literature. So that's the advantage of having such discussions. Great. So I move to the next question. So, I mean, again, this is also something which we have discussed over the last 30, 40 minutes. But again, Dr. Surya, so in which patient profiles and traits have you been currently prescribing? So this is not literature. This is your practical experience probably that Glenmark wants to have an idea on. So what have you been doing?
Yes, sir. As Dr. Joel mentioned, like in treatment naive patients, like suppose if they have a stigma about starting an inhaler, those cases we can start with a like 100 low dose Vilantrol flutic acid combination like once daily. In our patients who are already on inhalers who are not controlled with like high dose of formoterol and budesonide, or who's requiring more of oral steroids, or if they're having more exacerbation, like more than 2 or 3 frequent exacerbation requiring more than 2 times of 2 oral steroids along with even like IP admissions. In those cases, I would start this philantrol fluticasone. But only thing when this is given, this is mainly an advantage of smart therapy. But most of the time, even with the philantrol and fluticasone also, patient come back with exacerbation. In that case, we need to actually add a reliever medication also. And apart from that, patients who are having a like a fixed airflow obstruction like asthma, COPD overlap, those patients are benefiting with this Vilantrol flutic acid. They have a better symptom control. So in those group of patients, we can start, and patients having more frequent exacerbation or who's requiring oral corticosteroid usage for more than 2 times in a year. So those patients, I would recommend Vilantrol flutic acid.
Okay, so I mean, more or less the same things that the evidences speak, but just for my knowledge and what you all perceive. So definitely, Vilandrol is more cardio safe. But how do you perceive that adverse events like tremor and all compared to a salmeterol or a formoterol? I mean, your practical
So
experience,
yeah,
Dr. Surya,
so
also
far
understood.
not like mostly patient are having a good tolerance. Adherence also is good, tolerance also good. So far, I've not received any significant like side effects from the patient, like
Okay.
tremors or any dryness of mouth or those kind of complaints I have not got so far.
Okay. And suppose, I mean, theoretically, because Vilandrol is something that has a fast onset of action, theoretically, this also can be used as a smart. But since this is a long-acting one, if the patient uses this as a smart on 2, 3 doses per day, does it increase the risk of adverse events? I mean, at least practically, whether anyone has seen. I mean,
Yes,
it's open to all.
no, I have seen patients do that. definitely, because whenever you get an infective exacerbation or something like that, when it's a viral exacerbation or something, the patient starts using the same inhaler twice or thrice a day. So sometimes I've seen patients present with tachycardia, tremors, everything. But that is when the doses were taken. They had taken it 3 to 4 times a day. No matter how much ever we counsel the patient regarding the factor that it has to be used once a day, not preferably more than once a day. But still, I have seen patients using it because another important thing which I feel regarding all COPD, asthma, or whatever airway disorder patient is, whatever they get, whatever difficulty in breathing they feel, whether it's due to a GERD related breathlessness or if the cough is related to gastroesophageal reflux, everything they'll attribute towards asthma or towards a worsening of their primary obstructive airway component. So that time there will be an overuse, especially in a panicky state. So I have seen 1 or 2 patients who have presented with tremors and tachycardia, but in the previous day they had a usage of at least 2 to 3 puffs of the same inhaler. I mean, of Vilantrol fluticasone. Other than that, who have been using it once a day, I haven't seen much of the tremors or tachycardia.
Great. So that's why probably one of those flipper sides of smart, because unless you keep an upper ceiling for the smart dosages, you might be doing more harm than good. You may be missing a severe exacerbation or delaying a high-end treatment like a systemic steroid for a exacerbation. That's one of the flipper sides of smart. Okay, so we'll move to the next question from Dr. Joel. So, I mean, again, your personal thoughts and the evidence backup for that. So, if the patient is uncontrolled on a FB, like or low dose, 200 to 400 per day mcg of budesonide, then what do you usually do? Do you escalate the FB dose or switch to VF or directly escalate to triple therapy with whatever be that, BAD triple therapy or OD triple therapy or whatever be that? So, I mean, I don't think there will be a one single short answer to this, but probably we can get a thought process from everyone.
Sir, here I will be addressing the issue first. If the patient is having a compliance issue, then switching over to this FFVA combination will be a better idea. But if the patient is adherent, patient is having a good inhaler technique, then the same inhaler with a double dose I will be trying with the same inhaler with a double dose. Then we need to check whether the patient is a difficult to treat asthma or a severe asthma. If it's a difficult to treat asthma, as discussed earlier, we need to check the inhaler technique. Inhaler technique needs to be corrected. If there's a continuous exposure to the allergen, that needs to be avoided. And if there's any comorbidities are there, like GERD, cardiac comorbidities, obesity, if anything is there, that need to be corrected. If it's a severe asthma, then we have to see what phenotype that patient is going into. Then the therapy need to be selected based on that. That's my take on that, sir.
Okay, so I mean, I love two aspects which you said. One is individualization of the choice, and secondly, getting the basics right, including the inhaler compliance and techniques and all those things, comorbidities. So, I mean, those two are perfect, but you didn't give a single choice. Okay, that's because you wanted to be individualized. But suppose all those basics are correct, and then you have someone who is totally compliant, no comorbidities, correct inhaler technique, not controlled on, say, 400 budesonide. Which choice would you go for in this?
Sir, if compliant, I won't be changing the inhaler, so that will be a cost burden on the patient. So I will be giving the same inhaler with a double dose.
Higher dose. Okay, excellent. I mean, I want everyone to comment on this. Mujib.
In our practice also, the changing inhaler is very difficult. Patient will be cost-wise also, and they will be very adamant on the inhaler devices. If they are compliant to that device, I think escalating the dose will be a practically feasible option, because introducing a new molecule, new device, suppose somebody was doing MDI or DPI, changing to different molecule will be slightly difficult patient point of view. So if he's adherent to the medicine, compliant, then switching to a higher dose of existing inhaler will be more practical, as Joel is very correct.
Excellent. So, Adul and Surya, do you agree with the same thought process?
Yes, sir. I would also do the same. I would not burden them with one more inhaler. I'll try to increase the dose.
Okay.
of the same inhaler being used.
Thing is, if we introduce another inhaler, I'm pretty sure they won't use this one or the previous one. They'll stop everything like that.
Yeah, okay. So I think very practical points. Maybe this will summarize the panel's opinion, and it serves as a message to Glenmark also. So, I mean, if you want to position VF as a alternative to escalation of FB dose, then probably none of the consultants prefer that. So most of us would like to go on a medium to high dose of the existing ICS LABA before we start thinking of switching to a VF. Unless, of course, the patient is having a major ICS-induced or LABA-induced adverse event like pneumonia or a pharyngeal candidiasis with high dose and all those things. So by and large, all of us will prefer to escalate ICS LABA dose to the highest tolerated before we think of switching. That is the, practical point which most of the pulmonology consultants will do in our part of the world. We move to the next one. So when do you label a patient as difficult to treat asthma? And your approach to patients with frequent OCS uses more than 2 per year on formoterol budesonide. So I think again, going back to Mujib. So in two parts of this, I think the first one is more or less simple theory. So if someone is on frequent exacerbations needing OCS on formoterol budesonide, what would you do? I think probably we can take, it's a repetition of the previous one. So what we'll think is if the patient is on high dose formoterol budesonide and still having exacerbations, then probably what we'll do, I think we will make it that way.
So that will be more easy because we have to segregate the patient. Either they are a difficult to treat asthma patient or a severe asthma patient. So we have to start from the history, duration, their asthma compliance, the compliance to the inhaler, their other asthma-related comorbidity like allergic rhinitis, sinusitis, GERD, sleep apnea, and the device and the proper techniques. So this much will be evaluated whether we can segregate the patient to a difficult to treat asthma patient. If all these points are corrected, despite this, if they are on high dose inhaler, ICS LABA, or in the current last 1 year, and the symptoms are despite that is not controlled, then we have to think about a severe asthma algorithm. Severe asthma algorithm, then I think preferably going for a triple combination will be more better. Like in step 5 chemotherapy, I think going for a triple drug combination will be more. Plus evaluating for the type 2 inflammation, the IgE, the eosinophil percentage, the FeNO, and thinking the patient to a more severe asthma treatment algorithm will be more suitable for that scenario.
Okay, so again, I think I want the panels of all panelists' opinion on that. So the question burns down to this way: someone who is uncontrolled on high dose formoterol budesonide, would you like to go ahead with another ICS LABA like VF, or would you like to escalate to triple therapy? So Mujib is very clear that he will like to escalate to a triple therapy. What do others think? Atul?
Yes, the basic thing is firstly, we'll review our diagnosis and all that, all those workups and things. But I will try switching the molecule once to the steroid molecule to a fluticasone one if he is not improving on budesonide. Because personally, I have seen some patients who have improved with switching of molecules. Like they were not improving with budesonide, but when I switched over to fluticasone, whether it was propionate or furoate, there was some amount of improvement that was there. Obviously, the easiest part would be the patient is on formoterol budesonide combination. You can make it a triple inhaler with a formoterol budesonide and glycopyrronium combination. But if I am clear cut established that it's an asthma, I'll try switching over to the steroid. I mean, changing the steroid molecule once, and then if it's not improving, I'll escalate to a triple therapy MCC.
Okay, Surya and Joel.
So first, I will go on with like suppose if the patient is having like uncontrolled symptoms or anything, I will just look for whether the patient is progressing to a fixed airway obstruction or whether they're having a trait. So in those cases, I would like to go for a triple therapy. First, I would like to add a LAMA. And even with triple therapy, if the patient is not improving, I'll wait for 2 weeks to 2 months. If the patient is still not improving, is symptomatic, then I would like to switch the molecule. Otherwise, I would prefer going for a triple therapy.
Okay. And Joel?
Sir, I will be going for the reconfirmation of my diagnosis again, whether it's an ABPA or is there any EGPA involved in it. Then I will be, like Mujib sir told, I will be classifying whether the patient is difficult to treat asthma or severe asthma. Difficult to treat asthma, then the correction of comorbidities and the other coexisting factors. If it's a severe asthma, then I will be preferring a triple drug. Then if patient not improving, then going for the biologicals will be the better option.
Okay. So again, here the panel is slightly divided. So, I mean, there are two options. I mean, difficult to treat asthma, you evaluate and take care of those difficult aspects, then probably your asthma control is going to improve. So I don't think there is a controversy there. But someone who is otherwise optimized, requiring high dose of FB, there are two options. One is directly go to triple therapy or maybe switch. I mean, I don't think there's a very correct approach, 100% correct approach. It may be a personal decision with the patient, personal decision with the doctor. Maybe in this, you are justified in changing the ICS LABA, maybe try your VF because of logistical advantages or pharmacological advantages that we have discussed previously. But even if you decide that you are not going for VF and you are directly going for a triple therapy, that's also fine. But I mean, it depends upon your personal preferences and experience. But again, just to highlight that VF is a option here in those patients who are not controlled on high dose FB. So, I mean, this again is another thing which I don't think we will have a very clear-cut answer. So, do you think switching to VF can help in delaying the initiation of biologics in uncontrolled patients? I mean, I pass it on to Atul Francis, but then we can have again opinion of everyone.
So clinically, I don't think there is any data to say whether it can delay the onset of biologic use or anything like that. Because I practice in a hospital where I won't be able to prescribe biologics even to the patients who actually requires it because of the cost factors and other things. So my option, if an asthma is not responding to formoterol budesonide, is to try either a vilantrol fluticasone combination or to switch over to a triple combination. And then if nothing is improving, only then I can think about a biologics. So some patients I have seen who are not improving on your smart therapy, improving with the vilantrol fluticasone combination or improving with the triple therapy. But I don't know whether it can delay the consideration of biologics or not. But I have seen some patients who are not improving with budesonide combination, improving a bit with the vilantrol fluticasone combination or even the triple combination with vilantrol fluticasone and umeclidine. So some patients whom I could at least temporarily take away the option of biologics and use these inhalers for some more time, because patients in my place they cannot afford biologics at this point in time. So in such patients I have used it because I find it difficult to use biologics due to the cost factor. And I have seen I have seen many patients who have improved when I changed the molecule, but there are patients who have not improved also. And finally, I had to start them on biologics. So I can't give a clear-cut answer whether I can delay, but I have definitely seen at least 50-60% of the patients are still using the inhalers and they weren't needed to be switched over to biologics, but 20% I had to switch over to biologics. So an exact answer I won't be able to give it to you, but practically I've seen some patients whom I could prevent from going into biologics, and some patients who even after using this there wasn't much of a improvement.
I mean, I don't think any one of us will be able to give a correct answer to that, but I feel as of now, I mean, to the best of my knowledge, anyone can correct me. To the best of my knowledge, I don't think we have a data of VF, switching to VF and then making them, making biologic necessity less. I don't think we have a data like that. Maybe as Sadul said, in a very practical sense, because biologics are considered to be higher options, especially more costly options in countries like India, where we have to pay from our own pocket in a substantial majority. Maybe just like a logic or a practical thing, you can try switching. But rather than switching probably someone on a FB, probably you will think of, you think of biologics if the patient is not even controlled on a maybe triple combination and then montelukast and then sustained release theophylline and then still requiring frequent oral corticosteroids, spurts, or maintenance oral corticosteroids. These are the category of patients which you really think of biologics. So if the patient has gone to that extent, I don't know whether initiating VF can really reverse the asthma control. I have my own reservations on that. But maybe before you think of the fact that the patient has really no other options of asthma control, and since biologics are costly, you may be justified, but I don't think you can keep it as a dictum. This is my thought process. But Mujib, what do you think?
So there is one study I was looking in the literature. There is one study called the RARAC study, RACS. This is
Okay.
a Japanese trial. Who what they did is they switched the patients from salmeterol fluticasone and formoterol budesonide to the vilanterol fluticasone, and they observed these patients over I think 12 weeks. That means 3 months. It's an open label trial, and what they found is they change the medicines based on the patient's pre-existing dose. Suppose who are on low dose, they change to vilanterol fluticasone 100. Those who are on moderate or higher dose, they switch to the vilanterol fluticasone 200. And what they found is the asthma control has improved, the ACT has improved, and also they found the FeNO has reduced. So that's one element I feel at the end of 12 weeks, the FeNO is coming down in the patients who are on vilanterol fluticasone. In that aspect, I feel this molecule sometimes definitely improve the asthma control, and also can delay the jumping into a biologic because their asthma getting controlled, the type 2 inflammation is getting controlled, and they are on a potent steroid, and which has a very high bioavailability, and also it retains in the pulmonary epithelium for a long time. So in that case, I think there is a limited evidence, but I don't know how much it clinically correlate in other wild with a larger data. This is only one study, it's a Japanese study I could see.
Okay. Interesting. Maybe it's a food for thought. Probably, as you say, the inclusion of these patients were not severe enough to think of biologics, I suppose. But anyway, that's probably a launching platform to think whether VF can be used to improve asthma control to an extent that biologics may not be required. That was new for me. Anyway, thanks for highlighting that. Any opinions from Dr. Surya or Dr. Joy?
So instead of that, they mention like instead of mentioning like a delay in consideration of biologics, it can be put in the other way also, where we can avoid early initiation of biologics. There are group of patients like severe asthma patients, like for in those cases when they are not improving with like high dose ICS, in those cases we can definitely try with the high potent steroid like vilanterol fluticasone. We can give a try with vilanterol fluticasone and then go try for a biologics rather than directly going into biologics. That's what I would suggest.
Okay. Dr. Joy, anything, or shall we move?
Same opinion.
Okay. So, how do you foresee treatment algorithms changing with VF use in uncontrolled asthma, and where does VF fit into Indian asthma guidelines, and how might this evolve in the future? So, how would you position? This is something which we were just trying to discuss in the last 1 hour, but just to summarize it. Yeah, Dr. Surya.
Sir, usually we go with our old tradition is we used to start with the low dose ICS, then we add a LABA, then like we go with the medium dose ICS and high dose ICS with a LABA. But instead of going for a vertical stepping up, with the presence of vilanterol fluticasone, we can go for a lateral, like where instead of going for a high dose before after trying a high dose steroid, and if patient is like again symptomatic with high dose steroid, instead of shifting the treatment there in patients who are not controlling with low dose ICS or medium dose ICS with the LABA, we can directly go to a more potent steroid, which is having a longer effect. So I think we can place this use of vilanterol fluticasone when we are bound to use like medium dose steroids with a LABA and still patient is not improving. In those category, I think we can start using vilanterol and fluticasone. So I would like to place this drug when the patient is not improving with the medium ICS with the LABA.
Okay, so probably, as you said, one option would be start upfront and maybe start as a non-responding case,
Yes.
and maybe try rather than stepping up from the lowest to highest, maybe start off somewhere in the middle of that ladder. And if patient is controlled, try to step down. That's also an option. Maybe just like sepsis, hit early, hit hard.
Yes, same way in treatment naive patients also, like instead of starting them with a low dose ICS, I would better give the once daily drug, because that will definitely give a better adherence for them, and it will avoid stigma of using the inhalers also. In those patients also, I would like to start with the low dose Vilantrol and fluticasone.
Okay. I suppose others also agree. So in that case, we can just go to the last question. So with all the evidences, rationale, pharmacology, logistics, all those things that we have discussed till now, would you think of VF as a first choice ICS LAVA in uncontrolled patients instead of escalating dose of formoterol budesonide? Or would you think of VF as a first choice for maintenance treatment in treatment naive patients? So, this would be we'll start off with Joel, but since this is the concluding remark, we will take opinions from everyone. Joel.
I'll answer the second question first. First choice for the maintenance treatment in naive patients, yes. But the first question, as we discussed already, if the patient is on for formoterol budesonide, I will be checking whether the patient is adherent or not. If adherent, then I will be doubling the dose. If not adherent, then I will be shifting to Vilantrol fluticasone OD dosing.
Okay.
It will depend on what is making the asthma uncontrolled.
Yeah, individualistic. Okay, agreed. Totally agreed. So maybe we'll have opinions from everyone before we conclude in the next 3 to 5 minutes. So Mujib, from a commercial standpoint, from an ethical standpoint, everything put together, where does VF stand?
Sir, first choice as a new patient coming for asthma treatment as a maintenance therapy, yes, I totally agree on that. Second, as a switching from formoterol budesonide rather than giving a higher dose, trying Vilantrol fluticasone, I also discussed with the patient. I also look how long was the asthma and how long he was using formoterol budesonide. Sometimes what I have seen, giving the patient an option of a new molecule, explaining them this is a new molecule and this has a better lung, means better potency or better affinity or better ability to make bronchodilation or better ability to control inflammation. Explaining that factor, sometimes if patient agree, I think then switching the molecule to Vilantrol fluticasone is also justified. First choice as a new patient, of course, this will be a good choice. And as I mentioned, in the other case, I will be discussing the patient option of a new molecule, its benefits in terms of the pharmacology, in terms of the body dosing. Then I will be taking a decision.
Okay, thank you, Mujib. Adil.
Yes, first choice molecule will definitely be formoterol budesonide combination. Cost factor, long-term molecule which has been used for many years, the proven molecule. And obviously, if it's not improving on formoterol budesonide, my first step will be definitely increasing the dose of formoterol budesonide. And still, if not improving, I can try switching over to a Vilantrol fluticasone combination. And in the same time, I'd be looking for whether there is a fixed airflow limitation that is developing, whether he's going into a COPD, whether he requires a sustained bronchodilation, or he's going into is a type of AC or something. There, maybe I can think of using Vilantrol as an upfront molecule. Otherwise, initial molecule, if it's a clear-cut asthma, it will be always formoterol budesonide.
Okay, I think Vidya.
Even I'm more used to formoterol and budesonide, sir. So I would also go with formoterol and budesonide. Only if the patient is having very stigma about using twice daily inhaler, or they're very reluctant to use starter inhaler. In those cases, I would go for a Vilantrol fluticasone. Otherwise, I usually prefer formoterol budesonide because I see better control with that molecule. So I would prefer going with formoterol budesonide.
If I can summarize the opinions of the panel for the audience as well as even for the Glenmark
So
team.
before that, I have a question, sir. I just want to know about Vilantrol fluticasone being used as a reliever medication, like how effective it is. Because now we are using formoterol as a reliever medication, could see a better relief and better comfort from the patient. But how effective is Vilantrol as a reliever medication?
I think I will just tell my perspective and then I will go for others' opinion on that. My personal take is that although we haven't used it as a smart strategy, theoretically it should, in the sense because it's a fast acting, it's a long acting. So I mean, onset of action is fast, so there is no harm using it as a reliever, I feel, excepting the fact that it's a long acting one, multiple doses probably, although it's considered to be cardio safe, might trigger some cardiac events. We don't know. I mean, that's my take on that, but I will take everyone's opinion.
Sir, but when they
I strongly disagree on using a reliever, because reliever is something we have to use very frequently, and I think Villanol fluticasone we cannot use very frequently, and because of the cardio safety. Even if you read not only the Villanol fluticasone and the other meglitinium combination of triple drug also, the pharmacology and the manufacturer has clearly mentioned that this is only once daily and it should not be used twice daily, or it cannot be used as a reliever. So that has been there, and cardiovascular safety is the main concern. And second thing, I just want to discuss about how often you have find any pneumonia episodes in higher dose of Villanol. Any evidence? Even though literature is showing 4 to 5% of pneumonia, not in asthma, but mainly in COPD patients. So any other discussion or any take on message in that angle also?
My personal take on that would be, I mean, the overall incidence of pneumonia that we see is also pretty low. And then we are not very sure whether we can ascribe it to ICS use or the disease per se in COPD. But whatever published literature says that FP, that is fluticasone propionate, was associated with a much higher risk. FF and budesonide are associated with much lower risk, although slightly higher. So at a personal level, I feel I haven't seen much pneumonias, but I will open it up to everyone for their own experience.
But clinically, is it possible to differentiate whether it is because of a bacterial viral infection or because it was used because of the long-term use of inhaled corticosteroids?
That's the main problem with all the, I mean, accusations with all those studies, including torch and all those things. In the sense, they said that pneumonia increases, but mortality doesn't increase. But at one stage, exacerbation decreases, but pneumonia increases. How pneumonia was looked for in those studies. So that's a reasonably controversial aspect. So at a personal level, I feel in a carefully selected patient, if you start using ICS in a COPD patient who is carefully selected in low doses, I feel the benefits are much more than the adverse events. So, I mean, but literature says small, but definitely increases of pneumonia. So, because the literature is so robust and powerful on that, probably we cannot deny.
Because sometimes we are reluctant to increase a dose of inhaled corticosteroids, thinking of this pneumonia risk. But practically, in clinical practice, I am not was able to differentiate pneumonia because of per se infection or because of a long-term steroid use.
I think in asthma, we should not be hesitant to increase the dose of ICS because the risk of pneumonia is less well defined. COPD is the issue. I think COPD, the benefits, I mean, the exacerbation reduction benefits and anti-inflammatory benefits and such things of ICS plateau beyond a small to moderate dose, I suppose.
Sir, I mean, the symptom relief of the patient is also important. Quality of life is also important. So thinking about a pneumonia that can happen somewhere down the line. We should not be denying the treatment options which we have currently. So
Absolutely.
that quality of this thing is, and even an asthma exacerbation, even when we are admitting, even if the patient has a pneumonia, we are still giving him nebulized steroids there. So I don't
Correct.
think, and as ma'am definitely told, you can't attribute all those pneumonias just to inhaler use, right?
Correct. Maybe disease itself.
The
Yeah.
patient is anyways prone to pneumonias, anyways prone to infections, especially with the current situations and everything. So that's what.
Okay. So, I mean, if I can just summarize, so from the audience perspective, from Glenmark team's perspective, we have a very good ICS LABA combination in Villanol fluticasone. We are impressed with the theoretical and pharmacological advantages of this molecule. We are happy with the OD dosing, which theoretically and practically can increase the compliance. So many advantages, and we are impressed with some of those Indian evidences which say that this improves the asthma control in those patients who are even on other ICS LABAs and who are on traditional GINA management. A few concerns would be, I think, at different stages, all of you have raised. One is the dependency on BD ICS LABA usage. So that might be a challenge, at least partially emotional in some patients. That is one. Secondly, would be the cost difference. So that would be a definite aspect to consider when we are starting it upfront. Although we are very convinced with the pharmacological advantages. And third thing, I think Dr. Surya mentioned sometime that time test. I think even Atul said. So the combination of FB is time tested. So that way, in one moment, I don't think we will replace that trust and put everyone on upfront VF. But at least in some of those patients in whom affordance is not an issue, who probably want state-of-the-art treatment or who are not controlled on an alternate ICS LABA. So that probably will be the placement of VF in Indian practice. Upfront, in those patients who require state-of-the-art treatment, affordance is not an issue. Change if the patient is not controlled on an existing ICS LABA, but again with the caveat that many of us do prefer to go ahead with a high dose of ICS LABA of the same drug before we switch on to another inhaler. And even with high dose, some of us would like to go ahead with the triple therapy as opposed to a changing ICS LABA. But definitely changing an ICS LABA molecule is one of those options in the uncontrolled asthmatics. This is probably what came out of today's discussion. And Glenmark team also can add their perspectives or any queries that they want to ask to the faculty as well as delegates.
Yeah, so first of all, thank you so much for such rich and insightful session. Just to solve Dr. Mujib's query, sir, you mentioned about the cardiac safety profile of Vilantrol, right? Whether, I mean, you are not sure whether it's cardiac safer as compared to formoterol or not,
I
right?
think
No?
I think what Dr. Mujib said was, Vilantrol is a very cardio-safe molecule,
Okay,
but
okay,
if you start using it as a reliever and
Reliever,
you
yeah.
start using
okay,
multiple doses, then the cardiovascular toxicity might ensue. That's what he mentioned. No,
okay.
Mujib?
Yes, yes. Correct, sir.
Okay. Then I probably misheard something else. So I just thought of clarifying that thing. But yes, I think this I've been attending a lot of medical sessions on this topic, and I think this was one of the best session I have attended with a lot of insights. And I really liked this idea of Dr. Rajesh that he was provoking all of you to answer each of the questions so that we can get different perspectives and your clinical experiences on each of the questions, and also on what is your thought on Vilantrol and fluticasone. And definitely we will, Glenmark as a organization, we will try to come up with a lot of insights and the trials and studies on Vilantrol and fluticasone um, to kind of gain your trust on this combination. So we've already started working on it. Probably in this year we should come up with something concrete so that we can gain your trust for this combination.
Maybe if you are going for phase 4, Daksha, what I would tell is, especially if you want to cement its place as an upfront, you take newly diagnosed asthmatics who are ICS LABA naive, put them into 3 combinations, and follow them up at least for 6 months, if not 1 year. I mean, if you can do that, that would take a lot of effort and a lot of money. But if you can do that, and if you are confident that your molecule is going to pass that test, then nothing like it.
Okay, done. Noted. Point noted. We will try. We will just see at what stage we are, and basis on that, we will try to incorporate your suggestions.
Okay.
So I'll just, before closing the session, thank you so much, Dr. Rajesh, for sharing your thoughts and your insights on your practice and on this particular combination, and to our panel, Dr. Atul, Dr. Surya Kala, Dr. Joel, and Dr. Mujib, for sharing your insights as well. And currently, there are more than 250 doctors who are attending this session, and I am sure that your thoughts are definitely going to add a lot of values into their practices. So thank you so much for taking out time for your busy schedule. Thank you.
Thank you. Good night. And in fact, the Kochi people are going to meet again tomorrow for another another event.
Yes,
Mujib and
same
other event.
event.
Okay. Good night.